I'm here to talk about the major roles that the lab has to play in stewardship. The basic questions really boil down to this, though. Where does the lab fit in? And this little gal is actually our new yellow lab. She's now 14, 15 weeks. And so if any of you have raised a lab puppy, any puppy, you'll know to ascribe any limitations in this talk to sleep deprivation. But at this point, she's crate trained through the night, so I'm starting to catch up. So I'm going to be talking about really the most important roles that the lab has in promoting optimal antimicrobial therapy. And of course, as you all know, that means giving patients the right antibiotics when they need them and not giving patients antibiotics when they don't need them. So this workflow diagram is really how laboratorians think about what they do. They sort of divide time into 3 phases. Pre-analytic, that's anything that happens prior to a sample arriving in the laboratory. The ordering of the sample, the collecting, the transport of the sample. Then the analytic is the action that happens in the lab, processing the sample, testing the sample. And then post-analytic is everything that happens once you have the results of that lab test. How you choose to report the results of that test, and then importantly, because we see this as part of the continuum, is what intervention is made based upon the results of that test. And turnaround time, in my opinion, and I think in reality, is from the time that someone considers ordering a test to the time that an intervention is made based upon the results of that test. So when we focus on just the turnaround time of the test itself, the analytic turnaround time, we're missing a huge amount of what goes on in the laboratory. And opportunities for support of antibiotic stewardship occur at every phase. And that's how I'm going to sort of structure this talk about pre-analytic, then post-analytic. So with pre-analytic, we really want to focus on before the test is actually ordered. In other words, we want to try to make sure that tests are ordered in those patients that have a reasonable pre-test likelihood of disease. And if you take anything away from this, and many of you probably already understand this well, because it's Diagnostics 101, it's that the performance characteristics of any test, depend upon either what we call the pre-test likelihood of disease or the prevalence of disease in the patient population, if you want to look at it that way. And so as you know, if you have a patient who's been bitten by a tick, has a classic ECM rash, has a huge high pre-test likelihood of disease, if you get a negative test, you're probably going to consider it a false negative test, and it probably is a false negative test. Conversely, if you get a test in someone who has virtually no pre-test likelihood of disease, a positive test is far more likely to be falsely positive than truly positive. So diagnostic tests perform the best when there's an intermediate sort of a pre-test likelihood of disease. So a lot of what we can do to support stewardship and try to limit unnecessary antimicrobial use is to try to limit testing in the low pre-test likelihood population. I'm going to just give you a couple of examples, one of which Arjun already alluded to, which is on the issue of urine culture ordering. You could give now a whole hour-long talk on how to try to limit urine culture ordering. You could also consider radical things like closing down your urine bench for a month and seeing if anyone gets hurt. But I'm not going to suggest that. But I'm going to show you this one study because I like this because it has a concurrent control group. This was measuring the impact of a guideline-based intervention to reduce urine culture ordering. 2 VA systems were involved, an intervention site and a comparison site. They used a diagnostic algorithm taken from published guidelines. They did education using case-based presentations, and they used audit and feedback to reinforce that education. And sure enough, as you see on the graph there, the top dotted line is the urine culture per 1,000 bed days in the comparison or control arm, and you can see how it dropped in the intervention arm. And equally importantly, or more importantly, there was a decrease in what would be the overtreatment of asymptomatic bacteriuria in the intervention group. So just one example of a successful intervention to try to limit testing in that population that has low pretest likelihood of disease. C. diff test ordering is also low-hanging fruit, and I suspect, in how many of your hospitals are there interventions now that we would call diagnostic stewardship interventions around C. diff? Raise your hand if you're doing any of that. So quite a few. This was one of them that was done at the University of Virginia, where they used a computer decision support tool focused on stool frequency, requiring really that there be at least 3 loose stools per day before a C. diff test was ordered, limiting repeat testing. Some of these interventions also include limiting testing in patients who've received laxatives in the prior 24 to 48 hours. And this one, interestingly, also included a financial incentive for the providers and the units during this intervention if they decrease their C. diff test ordering. I'm not sure how I feel about that exactly, but it was a successful intervention. As you can see from the graph, the white bars are the tests that were prevented via this intervention, or the white parts of the bars on the post-intervention part. And they saw over 40% reduction in test ordering, and coincidentally, a 31% reduction in hospital onset C. diff infection. Because many of these diagnostic stewardship interventions, as you're well aware, are driven by the public reporting and financial disincentives associated with having high rates of C. diff infection and catheter-associated urinary tract infection. Sometimes, I think we have to focus also on what unintended harms can come from these interventions, but one of the benefits of some of these interventions is that they can decrease the unnecessary use of antibiotics if testing is appropriately prevented, because you're not going to get that treatment of asymptomatic bacteriuria or of mere carriage of C. diff in the absence of disease. So now I'm going to move to, from the test ordering, the decision to order the test itself, to sample collection. And the main point here to take home is, and this applies to, in particular, clinical microbiology, but all lab testing, garbage in, garbage out. So the concept here is to submit as little garbage to the microbiology lab as you possibly can by improving your sample collection. So there's a great review in CID that I've referenced here that just gives basic tenets of specimen collection. I don't think you're idiots, so I don't want to focus too much on collecting samples prior to antibiotic treatment. We all know that you should do that, but it's surprising the number of times when it could have been done when it wasn't. Always remember that a specimen is always better than a swab of a specimen. I think over time, most clinical microbiologists become irrationally angry about the use of swabs because we have situations where there's a huge amount of sample that can be collected and sent to the laboratory for analysis, and someone, I'm not saying it's usually a surgeon, just someone will, instead of taking a large piece of tissue or sample or pus, they will just take a swab, dip it in, and send it to the lab, which immediately significantly decreases the yield of that sample and your subsequent ability to narrow therapy based upon the results. Making sure you submit adequate volume for your samples, adhering to good transport conditions. If you think there's anaerobes involved, use anaerobic transport media. If a sample has to be refrigerated or needs some kind of special collection device, for example, for urine, for both of those issues, if it sits at room temperature on a counter, remember, bacteria replicate every 20 minutes. So that's going to affect the results of that sample. And then proper sampling site. And I have a Foley bag here, and obviously if you drain some urine for culture from the bottom of that bag, where that urine's been sitting there for a couple of hours, you're going to get a different result than if you use the sampling port. So all of these things that are pre-analytic, that happen before a sample gets to the laboratory. Just to give you at least a little data on this issue, this is a study that was done in neutropenic patients with fever that demonstrated that the diagnostic yield of blood cultures was 14% in those patients who got cultured before antibiotic therapy, only 7% in those who didn't. So focusing on that issue. And speaking of blood cultures, There is often some low-hanging fruit in blood culture collection that will have a positive impact on antibiotic stewardship. For example, if you don't have a good phlebotomy program, you're going to be using more antibiotics than you need to, because we've known for decades that well-trained phlebotomists have lower contaminant rates than physicians in particular, residents, nurses. So more contaminants, greater costs, more antibiotic use. Well-trained phlebotomists tend to fill the bottles the way they should be instead of putting low volume in, and perhaps the most important factor associated with blood culture yield is adequate volume. So if you don't fill blood culture bottles completely, you're less likely to detect bacteremia. You won't have data upon which to narrow therapy. Some of the practices that I was not aware were happening that you need to know about. For example, it's very common in an emergency department. Febrile patient, there's an order for 2 sets of blood cultures. An IV is started, 40 mLs of blood are drawn from that IV, and 2 sets of blood cultures are filled, which of course makes it very hard to interpret those cultures if there are common commensals or contaminants involved in that stick. And then finally, trying to limit the drawing of blood cultures through catheters, which are associated with higher contaminant rates. There's a nice review of this that I've referenced there. So now let's move from pre-analytic to analytic. So now your sample is in your laboratory. One of the first steps for many samples is to screen that sample and potentially reject it if it's not going to give you good information. The most common that you all probably know about is every lab does screen sputum samples to make sure that they're not working up oropharyngeal contaminants as opposed to the actual cause of a respiratory tract infection. So we look under the microscope. If there's more squamous cells than neutrophils, then that sample will not get cultured. Increasingly, labs are also screening urine cultures for the presence of white cells or inflammation before they proceed to culture. These are so-called reflex urine culture protocols. And it turns out to be a highly effective way to reduce the number of urine cultures performed. And I'll show you one of those studies in a minute. And then finally, no lab, unless you're doing a study of carriage, of asymptomatic carriage of C. difficile, you shouldn't be testing any stool that doesn't conform to the container, that's not liquid stool. So these are ways the lab can limit the workup of poor samples. So here's one study out of many that are published on the impact of implementing reflex urine culturing in your laboratory. This one was done at Maryland. They just started culturing urine only if there were greater than 10 white cells per high power field. They obviously excluded some patient populations, like neutropenic patients or patients prior to urologic procedure. But they found, as you can see on the left there, pre-intervention to post-intervention, significant decline in the number of urine cultures performed per patient days, lower bacteriuria rates, and fewer antibiotic starts for an index positive urine culture. Other centers have shown even more dramatic results in terms of decreasing urine culture ordering and decreasing antibiotic use for what is probably asymptomatic bacteriuria. Other analytic interventions, sometimes you might want to change a testing protocol to try to improve management of patients. One of the things that's happening now is that a lot of labs that implemented the PCR test for C. diff detection, very, very sensitive test that detects the gene, not the toxin, have started adding a toxin EIA when they get a positive test, not to say, well, this person can't have C. diff disease, but to provide that additional information for the clinician to help determine if they're dealing with C. difficile disease or infection, or if they're just dealing with the carriage of a toxigenic strain. And then the other that I'm going to talk about in more detail is picking some of your critical results in trying to implement some of the emerging technologies that give you faster organism identification, more rapid susceptibility test reporting, and the area where this is most commonly being implemented now are for positive blood cultures or bacteremia, and then some other of these panels like respiratory panels. And I'm really excited about this technology. One of the first studies that I did so I finished my ID fellowship, I went into practice for 3 years, and then I came back because I was interested in doing a fellowship in clinical microbiology. And one of the things that's always struck me is how much time and effort labs put into delivering accurate antimicrobial susceptibility test results to you, to us, to everybody. And so we decided we would look and see how much of an impact this result reporting actually had on antimicrobial use. So we looked at hundreds of bloodstream infections and looked at different time points. And this graph just shows you 3 of those time points. The phlebotomy that occurred at the time the blood culture, index positive blood culture was obtained, when the gram stain was reported from the newly positive blood culture, and when the susceptibility tests were finally reported. And you won't be surprised, but I was depressed that there was almost an undetectable amount of antimicrobial activity around the susceptibility test result reporting. All the action was earlier. And the reason for that is obvious. I mean, this was back in old days, right, around 2000. But the turnaround time for phenotypic susceptibility testing has long been of limited clinical relevance. So you have several of these you have time for organisms to grow in culture and then time for them to grow again during susceptibility testing. And quickly you're out 2 to 4 days or longer. Average lengths of stay now around 4 days in a lot of acute care hospitals. And those of us, most of you in this room are familiar with situations where patients are ready to go home and you're still waiting for the susceptibility test results. So it's really exciting now that we're able to begin to move this time period, compress it so that these results are more relevant. So sort of from a 30,000-foot view in clinical microbiology, I kind of think we're entering a middle period of time, not the middle of nowhere like this couple, but we're entering the middle between all culture-based diagnostics, where we get very, I think, useful results that can help us guide therapy, but not quickly enough, to a point where eventually we will be able to take advantage of advances in next-gen sequencing, in metagenomics, where you can just take a sample and directly determine immediately all the genetic material in that sample. Pull out the human reads, look at the microbial reads, know all the organisms that are present, what resistance genes are present, even how those organisms are related to other organisms that you've isolated in your hospital or region. So we are not there yet. We're not really even super close to being there. Although there are labs, you can take a biopsy of a chronic wound, send it to a CLIA-certified lab in Texas, and they'll tell you all the genetic material that's in that sample. I mean, what you do with that information is the question. But we're not at that point yet. But in the interim, we have a lot of exciting emerging diagnostic technologies that can reduce the time to organism identification, susceptibility test result reporting, that can impact patient care and improve antimicrobial therapy. The 4 I'm going to talk about are listed on this slide, and I'm just going to launch right in. So how many of your labs use MALDI-TOF for organism identification? A handful. So MALDI is a proteomic, I'm not going to tell you, well, it's matrix-assisted laser desorption ionization-time of flight. So that explains it, right? So you take the organism and you adhere it to a matrix and you hit it with a laser, and all the little molecules go down a drift tube at varying speeds based upon their mass to charge ratio, and basically it gives you a fingerprint. That's a very accurate organism identification, because depending on the part of the spectrum you look at. It's also very inexpensive after the initial investment. It's cheaper than conventional identification methods. So that's why it really has become used more and more widely. And the introduction of MALDI has been very successful. The main limitation still is that for clinical lab use, we require an isolated colony. So we're reducing the time from having an isolated colony to knowing what that colony is, but we haven't reduced the time to isolating the colony. With one caveat, there are modifications you can do, like from a positive blood culture, you don't have to wait until you get a big isolated colony to do MALDI. You can actually do a shorter incubation period and scrape that plate and get a faster identification from a positive blood culture. And that's what we've been doing in our lab to reduce the time to detection, identification of, say, Staph aureus from coag-negative staph. One of the interesting things about MALDI is that the precision with which we can identify organisms has some interesting unintended consequences. So a bug that you used to call a diphtheroid, you can now give a very complicated name that I don't even remember, right? So what does that do? Well, it seems clear from my experience at Iowa that if you call something an unusual name that a clinician hasn't heard of, they are more likely to treat that than if you call it a diphtheroid, where they might assume it's a contaminant. Similarly, the CDC definitions for bloodstream infection didn't have many of these organisms on their common commensal list because they just fell under this wastebasket term of diphtheroid. So there have been some real changes that have been occurring in the background to try to adapt to our ability to more precisely name things. The other thing that you have to do when MALDI comes in is meet with your laboratory director to say, a lot of these groups like Enterobacter cloacae, those are so familiar to clinicians and they have a meaning to them, and we don't want to lose that. So what groupings do we want to keep in those reports, even if in parentheses we put a more specific species identification in? But all in all, I think MALDI has been a win, and there are studies that have shown that it can decrease the time to appropriate antimicrobial therapy, and I'll show you some data included in a meta-analysis shortly. An interesting new diagnostic technology that you at least need to know about is magnetic resonance diagnostics. So this uses magnetic particles that are coated with these capture probes that target different organisms, and then you can take a blood sample, a short amplification step, and apply this test directly to a blood sample. And if the target is present in the sample, these little magnetic particles agglomerate and they produce an MR signal that can be detected by the instrument. So why do you need to know about it? This is the first FDA approved US FDA approved diagnostic method that's applied directly to a blood sample, not to a positive blood culture. So a lot of the tests that we are talking about, like the PCR-based, the BioFire, or other multiplex panels, are applied to a positive blood culture. This is not. There are published data for Candida. I'm going to be interested at ASM Microbe and going to see a lot of the posters on the bacterial panel because it was just approved this week, which is why I thought you'd need to know about it, because the people who sell these are going to be coming by and wanting to let you know that they are now FDA approved. So I can't talk in detail about this because we have not adopted it, so I'm not so familiar with it. I think one of the issues is going to be that this will be an add-on technology because you're still going to have to grow the organism to do susceptibility testing, et cetera, et cetera. So there's another new technology that is getting a lot of attention. This is called Accelerate, and it's a rapid phenotypic test system. This is applied to a positive blood culture, and it combines automated digital microscopy with fluorescent in situ hybridization like PNA FISH technology. So what you do is you take a positive blood culture. After initial processing, the bacterial cells are immobilized on a membrane. Then you do your FISH, your in situ hybridization, and that tells you what the species is that you're dealing with, or it tells you if it's a mixed culture because you'll see different color probes. And then you look at the behavior. I think this is pretty cool. You look at the behavior of these bacteria in the presence of a fixed concentration of antibiotic. Do they, like on the left, if they're susceptible, do nothing? Or on the right, when this E. coli, which is resistant to ceftazidime, is in the presence of ceftazidime, it starts growing these microcolonies. And the automated microscopy detects that and produces a result. So this is also now FDA approved. The difference here is that this met the FDA criteria for a susceptibility test, for a commercial susceptibility test. And they have, how many major errors, very major errors can you have? So you wouldn't have to do this in parallel with some kind of standard susceptibility test as long as the bugs and the drugs were included in the panel. So again, an interesting technology that can move you to identification and susceptibility test within 4 to 6 hours or so after the positive blood culture. And then finally, the molecular technologies that many of you are familiar with. There are a lot more multiplex and microarray panels coming out seemingly every week. A lot of these are sample to answer technologies. So like you can tell if there's TB and rifampin resistance direct from a sputum sample. Obviously C. diff toxin genes in a stool sample. Did I say stool or sputum before? Anyway, TB from sputum, C. diff from stool. Many of these can detect common resistance genes of epidemiologic importance. And you're familiar with, I think, at least those at UNMC, I think you're using one of these technologies where you have these massive panels, and you can look here at all the different organisms you can detect from stool, CSF, respiratory samples, or, again, positive blood cultures. And just a comment here, and that I'll get into a little more later. If you look at, if you remember sort of what we talked about pre-test likelihood of disease and kind of Diagnostics 101, if you have a test that detects 24 targets, right, what is the pre-test likelihood of disease for each one of those targets? Depending on the patient and their epidemiologic risk factors, the pre-test likelihood of disease is going to be a huge range. For some of those targets, a positive is meaningless. It's almost certain to be a false positive. For other of those targets, it's very important because the pre-test likelihood of disease is intermediate to high. And one of the unintended consequences we're dealing with now with these panels is trying to figure out, okay, my patient, and we get a lot of these calls, my patient had diarrhea, and I did a test, and it showed norovirus, but it also showed enteroaggregative E. coli. But by the time I called the patient to give the patient Cipro, he was better. So what should I do? So I think we'll get into this a little further, but the clinical validity of some of these test results, as well as sort of how clinical judgment plays into interpreting the results, gets increasingly important. So I've talked to you about these 4 different areas of progress with more rapid technology, MALDI and magnetic resonance and rapid phenotypic testing and PCR. So these all obviously cost. There's an initial big investment you have to make in bringing these in. Do they improve outcomes? And I think that they do. But I think we do need better studies to show that. So I'm going to show you a compilation of over 30 studies, almost 6,000 patients. That was a meta-analysis done by Tristan Timbrook and colleagues, where they looked at bacteremia management and how it was impacted by commercially available tests that could give you results in less than 24 hours from the time of the positive blood culture. And you can see the technologies listed there, many of them that I just talked to you about. The main outcome was 30-day mortality. Most were pre-post kind of quasi-experimental studies, and most had stewardship programs facilitating the intervention. And this is hard to see, it's the forest plot, but the bottom line is, if a stewardship program was guiding the intervention, there was a significant reduction in the odds of death at 30 days. Odds ratio was 0.64. It did not reach statistical significance when a stewardship program wasn't involved in facilitating the intervention. The number needed to expose to the intervention was 20, and the reduction in time to effective therapy was about 5 hours. The main limitation here is that almost all these studies were pre-post, what we call quasi-experimental studies. It's very hard to separate out the speed of the test, the analytic turnaround time from the impact of an active stewardship program or some other unmeasured confounder at the same time. But still, we'll take it, right? It improves. Rapid testing can facilitate stewardship and improve outcomes. But as I've already alluded, not everyone benefits from technological advances. And the one that I've alluded to and others that you know about is this question: when does lab detection equal infection? The two areas where we struggle with this the most right now in acute care hospitals and also long-term care and other settings is the presence of C. diff in the GI tract and the presence of bacteria in the urine. And I'm here to tell you that as diagnostics advance, this problem is going to be magnified because we're going to have increasingly sensitive tests that are going to be detecting gene products, not viable organisms necessarily. There are going to be multiple targets in a single test. And metagenomics eventually is going to detect all the genetic material in a sample. So we're going to have to ask the question repeatedly, what's the clinical validity of this test, or how has it been clinically validated? And then how does the clinical assessment play into how you interpret the results and apply them? It's kind of ironic because with machine learning and everyone says, well, clinical judgment is going to go by the wayside as we start to use AI and in advanced technology. And I'm here to tell you just the opposite, which is as diagnostic technology advances, clinical judgment is going to be even more important because we're going to have too much information and we're going to have to sift through it and determine what's clinically relevant. The other limitation that I'm going to talk about quickly here is that many of these new technologies are moderate to high complexity tests. So they have significant consumable costs and they have to be located in many cases in a central lab. But you guys know hospitals are merging, consolidating, laboratories are consolidating, and delivery models are changing. Care that used to be given in an acute care hospital is now in long-term care or home care. So that moves the diagnostics further away from the patient, which brings us to the issue of point of care testing. How to bring ID diagnostics closer to the point of care. This is a list from an article last year of CLIA-waived point of care tests for infectious diseases, because tests to be point of care in general have to be CLIA-waived. I'm not going to go through them all. I'm just going to make one point. More than 90% of these tests use the same type of format, a lateral flow immunoassay, which for many of the tests, they're quite good. The malaria lateral flow assays have really had a huge impact in malaria endemic areas, for example. But there are limitations to this format. The sensitivity is often lower than molecular testing. The older influenza point of care tests are a great example, just not sensitive enough to really help guide clinical management. And it's hard to multiplex these, which can be good or bad, depending on your perspective. But we are now starting to see more CLIA-waived molecular point of care platforms. Most of them still require a little machine on a desktop, but we're seeing increasing array of pathogens that can be detected by these point of care devices. So I think increasingly we're going to start moving some of these technological advances closer to the patient, which has the potential to have a more direct and more rapid impact on the patient. There's a lot of places that point of care testing is headed. Despite the abject failure of Theranos, microfluidic advances are being made that bring us closer to a kind of lab on the chip format. Smartphone applications are increasingly being utilized, sometimes to read or interpret tests, but also when you move testing to point of care, you have to be able to aggregate the data. Organisms of public health significance still have to be reported, et cetera, et cetera. So smartphones can be used to help to facilitate that. And then biomarkers, which again could be an entire talk. Biomarkers, there's a lot of work that's been done on biomarkers. This unreadable slide on your right, those are all different biomarkers that have been studied in different testing formats. But the road for this is quite long, and so we're still mostly talking about procalcitonin and CRP, but increasingly I think we'll be talking, as I'm going to mention, about gene expression signatures. So for procalcitonin, we know that randomized controlled trials do seem to show that you can reduce antibiotic exposure for anywhere from 2 to 4 days in an ICU environment without a negative impact on 28-day mortality through the use of serial procalcitonin measurements. But there was just a study in the last 2 weeks that seemed to throw into doubt the utility of procalcitonin that got a lot of press, so I thought I should mention it. This was a randomized controlled trial of procalcitonin versus usual therapy. Over 1,500 patients presenting to an ED with lower respiratory tract infection. No difference in antibiotic exposure between the groups. Now, the caveats to this are, think about how different this population is than an ICU population. The minority of these patients actually had lower respiratory tract infection. Also, these physicians in this trial were a very guideline adherent group. They were not treating for very long, even those patients who were diagnosed with lower respiratory tract infection. So I think what this shows us is that the performance and the utility, not performance, but mostly utility of a biomarker is going to vary dramatically depending on what population one applies it to. This is a really great study, I thought, because it combines all the things I've been talking about: smartphone technology, rapid diagnostic point-of-care tests, in improving the management of febrile children, in this case in Tanzania. So you can see those smartphone photos there. They put clinical information in there. They put the point-of-care malaria and HIV test results, CRP test results, procalcitonin, and then it follows an algorithm, and they were able to show decreased clinical failures returning to be hospitalized for a febrile illness, while also reducing antibiotic prescribing from almost 30% down to 12%. So I think really a really nice example of applying technological laboratory advances at the point of care, smartphone technology, et cetera. And then I mentioned already, this is where some of our biomarker stuff is going to be going, looking at host response signatures to determine if it's bacterial, viral, et cetera. And I'm going to refer you to this review in the interest of time. So moving now in the last couple of minutes to post-analytic interventions. This involves modifying how we report in order to improve antimicrobial therapy. Sometimes we report directly through a stewardship team. Sometimes you can do selective reporting or cascading of results to guide people to optimal therapy. Include clear explanations in your reports. This blood culture is likely to be a contaminant for these reasons. And then finally, cumulative reports or antibiograms. I love this study done in Canada several years ago where they just decided to not report urine culture results, which really would be illegal here, so I don't suggest that you do that. But they decided that in the non-catheterized patients, they just weren't going to report the urine culture results. They were going to require the clinician to call if they thought about it. Most of them didn't, and the decrease in the percent of patients treated with antibiotics for asymptomatic bacteria went way down, as you can see. And these brave Canadians, and this is a different group in Canada, just published this week this study, which also I thought was very interesting, a randomized controlled trial that modified reporting of positive urine cultures. They were selective, non-pregnant, non-catheterized inpatients, non-neutropenic as well. And so when they got a positive urine culture in the group randomized to the intervention, they didn't report the results. They reported this. This positive urine culture might represent asymptomatic bacteria or UTI. If you really suspect UTI, call us, and we'll give you the results. And they increase the appropriate therapy or non-therapy, as it may be, to 80% from 50%. Relatively small study, about 100 people included, but interesting. And also not sure that this would, I don't think we could do this in the US given our lab reporting requirements, but still, an interesting post-analytic intervention. And then selective reporting, I think your labs probably already do this. Instead of reporting all tested agents, just a limited number to try to drive use towards algorithms or guidelines or local preferences. This is a randomized controlled trial that shows how effective this can be. Those randomized to receiving all of the susceptibility test results versus a selective amount of susceptibility result were much worse in terms of guideline adherent therapy in several different UTI scenarios. So if you got selective reporting, over half the time in all 4 vignettes, you chose guideline adherent therapy, only 14% of the time if you got the whole gamut of lab results. How do you cascade? I'm going to let you use your handouts for this, but there are tables in the CLSI document that are a good start. These bug-drug combinations always test and report. These do it selectively. These only supplementary. And then you should go beyond that and use local guidelines to help modify your reporting. And then the last topic are antibiograms. There are CLSI guidelines for how to produce an antibiogram. It's actually more complicated than you might imagine. One of the most important things is to produce one regularly, at least every year. We like to include only species with at least 30 isolates, so you have a robust rate. However, I realize that for smaller institutions, long-term care facilities, et cetera, you may not achieve that number. So one way to approach that is to do a kind of rolling 3-year antibiogram, or however long you have to go back to get a larger number of organisms to inform your clinicians. Make sure you're not rolling surveillance isolates into your antibiogram, and that you're only reporting drugs you routinely test. If you report drugs that you only test on resistant strains, you're going to get a very skewed antibiogram. And then finally, we only report the results for 1 patient isolate per period, so you don't have a situation where you have 1 patient admitted with Pseudomonas, gets 20 respiratory samples that kind of skew your antibiogram. And then, as I said, this isn't straightforward. In the largest study of antibiogram preparation, over almost 30% of hospitals had at least 1 major error in their antibiogram presentation. The other thing I didn't mention is, in a large center in particular, presenting antibiograms that are unit-based or age-based, because susceptibility rates vary dramatically in different patient populations. This is just one study from Mayo showing how susceptibility rates vary by age for key bug-drug combinations. And then lastly, producing an antibiogram isn't enough. It has to be readily available to your clinicians. We've found this app, the MicroGuide app, to be really helpful. It's on, I can in 2 seconds pull up our most recent antibiogram online. It can be updated regularly. You can include all sorts of other infection control and pharmacy information, as well as our antimicrobial guide. How we suggest different common infections be treated are also included in this app. And it's gotten very good uptake. So in summary, it's obvious that the lab needs to be integrated into every antimicrobial stewardship program, and there are opportunities at every phase of testing, pre-analytic, analytic, and post-analytic. In the future, I think we'll be bringing the lab closer to the point of care. And remember that as diagnostic approaches advance, it's going to challenge your stewardship program with what I call too much information as we start doing more of the metagenomic type testing. All of this, of course, requires good communication and collaboration. I've been really impressed, like last night at dinner and talking to people here and knowing Mark for a while, at the degree to which there's a lot of collaboration going on here between acute care, long-term care, the public health department, the CDC. It's really very impressive. So thank you very much.